Hi everyone. As you know, oncology is really big these days. Let's assume for a second that I have responsibility for oncology. So, what databases should I be looking at, JP?
I think the free databases, EMR, claims, and primary research surveys. EMR, because it's clinically very rich, it has a profile of the patient. For example, for breast cancer, we have ERP or HER2. We have lab values, we have lines of therapy. It even has physician notes, which may shed light on the rationale for the treatment or changes in treatment of the patient. The second one is claims, and actually there are two types of them. First one is syndicated or open claims, and that's very interesting because it exposes the ID of the physician. And it doesn't have the clinical granularity of the EMR, of course. The second one is closed or payer claims, and they do not in general expose the ID of the physician, but they have lab values. The third one is PR, primary research panel, and they're great to track market share, especially when we're looking at combo usage.
I see. Great. So, there's going to be big holes in these databases, right, JP? As I say this because data blocking is very prevalent in oncology, and especially because manufacturers usually ask majority of the SPs not to share their data with the syndicated data sources in particular. So,
Well, the good news I have for you is that EMR and closed claims are immune to data blocking. The reason for that is that the EMR in the physician office captures the prescription of the drug, regardless of the drug that is being dispensed, and that could be IOD in office dispensing or through an SP. It is the dispensing that is subject to data blocking, not the prescription. As for the closed or payer claims, the payer needs to see the claim to make the payment. So this means that the EMR and the closed claims are going to be immune to data blocking. Just a quick comment here, Shanmugam. Both EMR and closed claims have one significant drawback, and it is that the physician ID is not exposed, which makes targeting a headache for us.
I see. So should I conclude that EMR and close claims are only good for strategic analysis but not for tactical operation, JP?
That's correct. But if you could expose the ID of the providers in the EMR and the closed data assets, then the EMR and closed data assets would be even more potent than open claims data.
I see. Great. So how can we expose the ID of the provider in this case? I think we need PHI on maybe all different data assets we wish to combine, but that's very hard to achieve, right? There'll always be one vendor, one data vendor, who's not going to be excited to play ball. The challenge I see is this, JP. The same patient may be coded as 123 in the EMR, XYZ in the close claims, and as ABC in the open claims. How would we recognize that it's the same patient that we're looking at?
That's a very good comment that you're making. I have some good news for you. We have developed here an algorithm that is exactly what you're talking about. It combines data from an EMR with an open data set, and also from a closed claims with an open data set. And the magic, if you want, of the algorithm is that it recognizes when we're looking at the same patient and when we're looking at different patients.
Oh wow, that's really cool. I like this. This means that you can combine several EMRs or even payer claims with the same data asset, same open data asset. Is that right, JP?
Yep, absolutely.
Oh wow, very nice. So great. So see you guys. Bye-bye.
Bye.